Hello, I'm Michael Brennan. I'm Director of the Pain Center of Fairfield in Fairfield, Connecticut, Senior Attending Physician in the Department of Medicine, Physical Medicine and Rehabilitation at Bridgeport Hospital in Bridgeport, Connecticut, and Associate Medical Director for the Chronic Pain and Recovery Program at Silver Hill Hospital in New Canaan, Connecticut. I'd like to welcome you to this interactive exchange program. During today's sessions, we're going to focus on the essential elements of responsible opioid prescribing for chronic pain. This will include recommendations on identifying patients who are more likely to benefit from long-term opioid therapy, screening for characteristics that have been linked to increased risks of opioid misuse or abuse, and individualizing opioid-based treatment and monitoring plans to address each patient's analgesic needs, functional goals, and risks for aberrant drug use. However, before we dig into these important clinical topics, let's take a moment to review how the pharmacology of prescription opioids relates to our endogenous opioid system and other physiologic processes. During the processing of painful inputs, noxious stimuli detected in the periphery are transduced into electrical activity in primary sensory neurons called nociceptors. Activated nociceptors transmit neural signals from the periphery to the spinal cord, where they release excitatory neurotransmitters such as glutamate and substance P. These neurotransmitters activate second-order neurons in the spinal cord or brainstem, which carry the pain signal up to the brain. Endogenous opioid peptides modulate nociceptive signaling all along this neuroaxis, from the periphery sensory neurons to higher brain areas. Various peptide ligands preferentially bind to three types of classical G-protein coupled opioid receptors, namely enkephalins, which interact with delta receptors, dynorphins with kappa receptors, and endorphins with mu and delta receptors. Opioid receptors are expressed throughout the central nervous system. In particular, high concentrations are present in the limbic system, hypothalamus, medial thalamus, brainstem, and spinal cord, all of which function to integrate nociceptive signaling. Opioid receptors are also concentrated peripherally in the gastrointestinal tract, where their activation reduces motility and increases fluid absorption. Looking more specifically at the analgesic effect of opioids, mu-opioid receptors in the substantial gelatinose of the spinal cord are thought to play a particularly important role. These receptors are located both presynaptically and postsynaptically at the first central connection between the first-order nociceptors and the second-order neurons that carry pain signals up to the contralateral spinal cord to the brain. Presynaptic receptor activation inhibits the release of excitatory neurotransmitters, whereas postsynaptic ligand binding reduces the responsiveness of the second-order neurons to excitatory inputs. The result is a dampening of incoming signals generated by painful stimuli. The localization of opioid receptors helps explain the clinical effects that we observe when we prescribe opioids to our patients. These medications can be categorized based on their affinity and selectivity for various opioid receptors, pharmacodynamic effects, and pharmacokinetic profiles. For example, the opioids that we use as analgesics are primarily agonists of mu-opioid receptors. By activating these receptors in the central nervous system and the gastrointestinal tract, mu receptor agonists induce many of the desirable and unwanted effects of opioid therapy, including analgesia, respiratory depression, sedation, constipation, nausea, and elevation in mood. Importantly, however, although commonly prescribed opioid analgesics are agonists of the same mu-opioid receptors, the analgesic and non-analgesic effect of these drugs are often highly variable in a given individual. Moreover, the responses of two patients to a given opioid medication will also frequently differ. The mechanisms underlying this variability are multifactorial. For example, population studies have uncovered alternative variants of the mu-opioid receptor gene and small genetic polymorphisms in opioid receptor and downstream metabolic enzymes. These genetic variations have been shown to contribute to differences in dosing requirements and emergent side effects among opioid-treated patients with acute or chronic pain. Additionally, despite their similar mechanisms of action, the mu-agonist opioids differ in their relative binding affinities for mu receptors and abilities to interact with other classes of opioid receptors. There are also differences in the metabolic pathways that produce or clear the active analgesic molecules associated with each agent. The primary route of metabolism of oxycodone, hydrocodone, fentanyl, and methadone is the cytochrome P450 system, whereas morphine, hydromorphone, and oxymorphone are biotransformed by glucuronidation. The different pathways that clear the drugs can have important clinical implications. For instance, because glucuronidated metabolites are secreted in urine, individuals with consistently impaired or potentially more problematic fluctuating renal function may experience enhanced analgesic and non-analgesic effects with drugs cleared via this metabolic pathway. Finally, each of the mu-agonist opioid molecules is available in different formulations, such as immediate release or extended release, or medications that have been designed to resist or deter certain forms of opioid abuse. Part of today's program will focus on specific characteristics of the different opioid molecules and formulations that can help us determine which medications may be better suited for a given patient or a particular role within an opioid-based regimen. On the other hand, the marked inter-individual and intra-individual variations in responses to opioid analgesics suggest that switching between opioid drugs may help us achieve better outcomes when our patients report poor analgesia despite appropriate dose, titration, or intolerable side effects that outweigh potential benefits from the pain relief. I'm now going to turn the program over to Dr. Gooden and Dr. McCarberg, who will lead you through a case-based presentation that highlights current best practices for the opioid-based treatment of patients with chronic pain. Thank you for your time today, and enjoy the rest of the program.